Sir, anybody can present, sir. There is no need to make them host, sir.
Okay.
Good evening, Dr.
Good
SBS, sir.
Good evening, Dr. Somasundaram.
Good evening, SBS sir. Good evening, sir.
Subramanian. Good evening. Good evening.
Hi, sir. Good evening, sir.
We are YouTube live also right now. So we are gone live. So those who are not able to access to the Zoom can also go through our YouTube channel, sir.
Rajeevan sir is not joined live.
Yes, sir. Dr. Madan, you are here.
So Dr. Rajendran has not joined. I think we should give him a ring, sir.
Sir, I am calling him.
Yeah.
Thank you, sir.
Just he is not responding.
Sir has joined.
Oh, okay. Then.
Good evening, Dr. Rajendran.
Hi, good evening, sir. President.
Sir, good evening, sir. Good evening, sir.
I'm just calling you. I'm just
Sir,
calling.
sir, sorry, sir.
Okay.
Good evening, sir. President, sir.
Sir, good evening, sir. Good evening, sir.
Sir, good evening, sir.
Sir, it's 8:01. Shall we start, sir?
Yes, sir. So all the primary invitees are here. We will start, sir.
Yes,
The
sir.
presenter has come, sir. Please check that.
Dr. Madan, you are here.
Madan is here, sir. Presenter is here. There's the Madan here.
Okay.
Dr. Madan, if you're there, please unmute yourself and speak up. Prasanna, if you can talk to him on the phone, it will be great. We'll, in the meanwhile, start the inauguration.
Yes, sir.
Thank you. So, a very warm welcome to every one of you. I'm Dr. Subramanian, Secretary of the Indian Academy of Pediatrics, Chennai City branch. It is indeed an honor to welcome you all for today's Gurukulam event. And today is a inaugural event, and we have with us the President of the IAP TNSE, Dr. Rajendran K. Sir, welcome to the event, and it's indeed a great honor to have you here to grace this occasion. With us is also Dr. M. Singaravelu, the Vice President of South Zone 2024. Sir has always been a great supporter of academics and also been with IPCCP for all its great events. So, sir, thank you so much. Your presence boosts a lot of morale for us. Warm welcome to Dr. SBS sir, teachers of teachers. Sir, you taking over the mantle of, as a convener of this e-Gurukulam has really added a lot of value and importance to the event. And thanks, sir. Without you, this is not going to be possible. And of course, welcome to our own president, Dr. Somasundaram, whose vision has created, we have been able to do all these things. Thanks for guiding us through it. Somasundaram, sir, please take over the proceedings.
Yeah. So thank you, Dr. Subramaniam, sir, for initiating the proceedings. So this is an routine PG teaching program, the old wine in a different bottle, and with an eminent persons with us. So this is termed in a different way. It is by virtual Gurukulam because we all learn from our gurus, and our gurus will be here on a monthly basis at 8 p.m. on a Tuesday to teach us. And so to inaugurate this virtual Gurukulam, we have our Honorable President, IAP Tamil Nadu State Chapter, Dr. K. Rajendran with us. So he will be inaugurating this session. Also, we have our Vice President, South Zone, who will be felicitating the event. And we have our mentor and our academic guru, Dr. S. Balasubramaniam. So he will be, I approached him to be the convener for the program for all the 12 series. With immediate hands, he has accepted to be the convener for all the 12 programs and guide us with the topics and the faculty identified for the 12 programs. So to start with, I request Dr. K. Rajendran sir, President of IAP Tamil Nadu State Chapter, to inaugurate this virtual Gurukulam and start the proceedings, sir. Thank you.
So, thank you, Dr. Somasundaram, President-elect, and respected teachers of teacher, Dr. S. Balasubramaniam sir, and our National President candidate and VP South Zone 2024, Dr. Singaravelu sir, and respected our President-elect, Dr. Somasundaram, and Chennai CCP Secretary, and other dignitaries in the platform, Zoom platform. And it's my great privilege and pleasure to be here for inaugurating this event. And as you vividly remember that we have started this PG teaching program during COVID time. I think the Tamil Nadu only that started this PG teaching program. And after that, followed by its national wide, it's actually popularized. And thanks to our dynamic President-elect, Dr. Somasundaram, and has taken over as a CCP President. Now he's started once again the PG teaching program with teachers of teacher, Dr. S. Balasubramaniam sir. Actually, last 1 week back, I think Dr. S. Balasubramaniam sir has organized on at a vaccination meeting. I think in Zoom. I think currently 2,400 viewers within a week. I think it's a record breaking, and really thankful to Dr. S. Balasubramaniam, and I think that Somasundaram has really selected key persons in key position, and I think this teaching program will go for all over India. They will go for viewers also, and my hearty wishes to Dr. Somasundaram, and he's going to be a good president for IAP Chennai and as well as for IAP Tamil Nadu in 2026. Thank you very much. Thank you very much.
Thank you, President Sir, for your kind words. So we follow you. You have already started in Tamil Nadu this program in the first week of January itself, on the 4th of January, the postgraduate program. So with your kind words, this program, I believe this will be a successful one from the Chennai part for the whole year, sir. Thank you for your presence and gracing the occasion, sir. Thank you, sir. Next, we have our Vice President of the 2024 South Zone Vice President, Professor Singaravelu, sir, an aspirant for the President for the year National IAP for the year 2027. Sir, please grace this occasion and felicitate with a few words.
Thank you, President Dr. Somasundaram. Good evening to all. The most respected President of our prestigious branch of the state, Tamil Nadu, Professor Dr. Rajendran, teachers of teacher and my own mentor for so many decades, Professor SBS sir, Secretary Subramaniam, Treasurer Nisha ma'am, and I'm happy that all the UB members, Annamala Vijayaraman sir, Amal, and all seniors have joined this program. More than 65 members in the peak time of practice, and also in YouTube, so many PGs have joined. Now, let both the state IAP Tamil Nadu and Chennai City branch, I think our SBSR will agree with me. Both the president, because of their vast experience and commitment in our IAP, their action plan, which has never heard of such a elaborate, covering all aspects of both community for pediatrician as well as postgraduates and everything. So this time is nearly going to be a wonderful year. That too, the members who have been given the assignment. See, the Gurukulam, Gurukulam. Who else can be a convener? A person of international repute has accepted to be this, and it is going to be initiated today. As an examiner and teacher for more than 3 decades, wherever postgraduates we are visiting, that to the topic selected today, people are not even understanding the basic of CNS examination. We find it difficult. So you have appropriately selected a cerebral palsy. Though you have been, wherever this is a case is kept for all the examination, because nowadays we are losing all other CNS cases for postgraduate. This is a case available, but still we find it difficult for the students. Definitely, this will become more than 80 people are joined right now. So by the time our SBSR start and Madan is going to present, definitely that is why I'm taking 1 minute extra, so that I want the benefit go to all the participants. That's why I'm taking being an inaugural meeting. So I request all the participants in future, be in time. Always SBS are known for punctuality, being a convener. Definitely he will start program very early. I wish definitely this program will be beneficial to the young budding postgraduates. It is not only for postgraduate and also the practitioners and also for teachers like us, so that we can learn each and every day from this program, and people like SBSR who will be always teachers of teachers. Definitely it is going to be a very successful program, and I congratulate our president and his team under the leader convenership of Professor SBSR, with ably supported by Secretary Subbu and Nisha ma'am, and all the EB members of Chennai City branch and the EB members of Central IAP of Chennai. Definitely it is going to be a very big and useful program. With your permission, I will be forwarding all this in future program throughout India, so that PGs of all over India will be definitely benefited through YouTube and others. With this, I thank once again the IAP CCB for giving me this wonderful opportunity, both during the installation function and also first academic program. Thank you all. Wish you all the best. Thank you for once again for giving me this opportunity, sir. Thank you.
Thank you very much, sir. You will be with us all through the year till you become the president of Central IAP, sir. And again, when you are, sir. So it's very happy to have 82 participants on board here. And I can see a lot of EB members of Chennai State, Chennai State EB members also are on board. And this is made possible only by the presence of our teacher of teachers, Dr. S. Balasubramaniam, sir. When I completed my secretary, I wanted to become president of Chennai IAP, Chennai City branch. When I completed my secretaryship in 2015, one day or other, when I become Chennai State branch president, I had in my mind that Dr. Balasubramaniam sir should come in some form or other to help me in my academics. So this, I approached him, and he was kind enough to take the role of the convener for the PG teaching program. And he has consented to join in all the 12 months program along with the faculty and the guru and the session and guide them accordingly. Sir, please grace this occasion with your few words before we start the proceedings, sir.
Good evening, friends. At the outset, I'm thankful to the officials of the Indian Academy of Pediatrics Tamil Nadu State Branch, starting with Dr. Rajendran and my good friend Dr. Singaravelu, Dr. Somasundaram, Dr. Subramaniam, and so many other seniors who are here for this, including Dr. Nisha of the Chennai IAP and Dr. Annamalai, my good friend. I'm a little nervous today for two reasons. One, Dr. Somasundaram told me that you have to convene meetings over a period of 12 months. So I have to be there for every meeting. And second thing, he told me the first meeting you be the teacher. That's fine. And third reason is the expectations are, I'm afraid, very high. You know, sometimes I feel these days it is far easier to be a student than a teacher. I'm really jealous of all the students. I wish I had so many teaching programs when I was a PG. No, we didn't have so much. You're all being spoon-fed. And I wish I could do MBBS again. I could join MD again and attend all these lectures. I would love to attend everyone. And in fact, I'm going to plan the next 11 sessions along with none other than Dr. Prasanna, the best outgoing student of KKCTH and the national gold medal winner in DNB. In fact, Dr. Somasundaram has chosen the right person to help me. In fact, he is there. The credit may go to me, but I think there's only Prasanna who is going to deliver the goods. Right? Prasanna will take it forward. And a few things I have planned. One is that instead of the prefixed matches we see in presentations, I'm going to have only 2020 with the teachers not knowing everything about the case. Sometimes I feel it's really not real if the teacher knows the case, knows the diagnosis, then comes and listens to a student and reads overnight and comes and says something. That's not the way PG clinic should be conducted. So Prasanna, I would request you to plan in such a way. We'll have one teacher from the local institution, one teacher from elsewhere. And the local teacher, okay, he can choose the case. But let the other expert, let him be blinded to the case so that it's really, you shouldn't even put a diagnosis in the pamphlets that you are going to distribute so that it makes a real good match. Okay, not a prefixed match. I hope, Prasanna, you will be able to do it.
Yes, sir.
Okay, that's what I have planned. And we will start all the programs at 8 o'clock. And of course, it can go on up to 9:30, 10 o'clock. For somebody like me, it's very difficult to stop me before 1.5 hours. There may be others who may not be whom you may not be able to stop even at 2 hours. So it can go on between 8 and 2. And we'll have different systems. We'll have different cases, different senior teachers from various institutions, and we'll try to make it very successful. I request all the PGs to utilize this opportunity. And again, I thank the AAP officials for this brilliant idea. Brilliant idea. Hats off to you. You know, I was also president of Chennai City. I don't do even one hundredth of what Dr. Somutharam is trying to do. This space is, you know, I mean, fantastic, fantastic. He started. I mean, it's almost like an IAP president's action plan, national president's action plan. Chennai City's action plan. I was amazed. Fantastic. I mean, that's what youngsters these days can do. All the best to all of you. Thank you very much.
Thank you, sir. Thank you for your kind words and your contribution all through the year, sir. And as you rightly said, I didn't know that when I chose Prasanna for coordinating the PG teaching program that he was an DNB student. This is way back 4 weeks ago. After that, we came to know that he's good, and Dr. Nisha will also be coordinating with you, sir. Another thing, whichever day of the week in the last week you are comfortable, we can plan the program, sir. But we'll see to that you are there for the program on that day, sir. We'll plan accordingly, sir, not on a fixed day, sir. So without wasting much time, I request our coordinators, Dr. Prasanna and Nisha, to take over and go to the case proper. We have 99 participants on board, sir. Thank you, sir. Thank you for a vote of thanks. Subbu, sir.
Yeah, Nisha will give the vote of thanks. Ma'am, Nisha ma'am, please, few words.
Thank you. Thank you, Dr. SBS, for agreeing to be the convener. Actually, a convener for this series. As you said, so many interesting ideas, and thank you to Dr. Somasundaram for this excellent idea to have this this type of PG teaching program. It is unusual. Thank you to our chief guests, Dr. Singarvelu and Dr. Rajendran, for gracing us with this occasion, and Dr. Singarvelu as he stands for the IAP president-elect for the next year. Without further ado, and Dr. Prasanna for putting so much work into this. So without much further ado, let's go ahead. Thank you very much.
Prasanna sir, can you take over the scientific program? We can start.
Dr. Madan, can you start your presentation? Can you share your screen now?
Yes, sir. So screen's visible, sir?
Yes. Can you make it a full screen? Slideshow. I thank Dr. Ganesh from Rainbow Children's Hospital, my dear friend Dr. Ganesh. With a short notice, he accepted the offer, and he prepared his postgraduate for presentation. We just gave 4 or 5 days for them, and in future, we'll start, as I said, we'll plan a proper 2020 match. So today our league stage starts. Dr. Madan, you can start.
Yes,
Yeah,
sir.
Dr. Madan, please be relaxed. Don't be nervous. In fact, the plan. In fact, I spoke to Prasanna this afternoon. The plan is that Dr. Prasanna will be the lead discussant, and I will pitch in wherever it is required. So don't worry. Dr. Prasanna will be the main discussant for your case, for your discussion. Don't worry. I know very little about this case. You know much more. Okay, please go ahead, introduce yourself, and all the best to you.
Okay, thank you, sir. Good evening to all. I am Dr. Madan, final DMD PG at Rainbow Children's Hospital. Today I am going to present a child with developmental delay and seizures. Master X, 4 years, 7-month boy from Chennai with informed being a grandmother with reliable information with underlying history of developmental delay and epilepsy since 6 months of age, now presented with complaints for fever for 7 days, cough for 7 days. Since a developmental delay with significant perinatal history, I would like to start with antenatal history. Antenatal history, first trimester, mother age at conception 29 years, father age 29 years, conceived after 7 years of marriage by IVF conception, no previous abortion. Dating scan done at 2 months of gestation revealed twin pregnancy. Folic acid tablets taken regularly. No history of fever with rash. No history of drug intake. No history of chest X-ray. CT scan during the first trimester. Second trimester, quickening felt at 5th month. Mother was diagnosed to COVID-19. No regular antenatal visit due to pandemic. TT injection given. No history of pregnancy-induced hypertension, gestational diabetes mellitus. No history of leaking PV. Third trimester, fetal movements pursued well. No history of bleeding PV. No history of GDM. No history of foul smelling discharge. No history of fever. No history of UTI. Developed pedal edema around 30 weeks of gestation, for which evaluated and diagnosed at pregnancy-induced hypertension and hospitalized for 1 month. In view of uncontrolled PH, emergency LSC is done at 34 weeks of gestation. Natal history, born at 34 weeks, emergency LSCS, twin 1, birth weight of 1.4 kgs, boy not cried at birth, cried after initial resuscitation, details not available. Twin 2, girl baby, and she was normal at birth. Shifted to NICU in view of respiratory distress. He was started on nasal oxygen and started on tube feeds by day 3 of life. After 1 week, he was weaned to room air and started on Palade feeds and tolerated feeds well. Child was discharged day 25 of life with adequate weight gain and discharged with on Palade feeds. No history of neonatal seizures, jaundice, hyperglycemia. After discharge, he was well till 6 months of age. After that, he developed multiple episodes of seizures in form of vacant stare and jerky movements of both upper limb and lower limb, which was settled in 3 to 5 minutes. Initially, grandmother was not aware of seizures and he was kept at home. As there was increase in frequency of seizures around 8 months of age, went to the nearby hospital. For the above complaints, they consulted a pediatric neurologist and evaluated with EEG and MRI brain, which was said to be abnormal and also noticed to have developmental delay. Parents were counseled regarding the same, advised for regular follow-up and started on anti-seizure medications and physiotherapy. Since then, he is on regular physiotherapy and anti-seizure medications. Last seizure was in July 2024, which was prolonged for 45 minutes, hence hospitalized and treated. History of delay in attainment of developmental milestones in 8 months of age. Gross motor head control attained at 7 months, rolls over attained at 8 months, sits with support attained 4 years, and sits without support around 4 years, 3 months, and stands with support around 4 years, 7 months. Developmental quotient is 16%. Fine motor, bidextrous reached by 8 months, unidextrous reached by 3.5 years, and pincer grabs around 4 years, 3 months. Developmental quotient is 21%. Personal and social adult milestone. Social smile 4 months, recognizes grandparents and sister 1 year, turns to call by 4 years. Developmental quotient is 21%. Speech and language, cooing 5 months, monosyllables 1 year, bisyllables around 2 years. Speak amma, appa 1 to 2 words are 4 years. Developmental quotient is 21%. Vision, able to fix and follow objects. Hearing, turns to sounds and smiles to familiar sounds. Overall developmental quotient is 19%. It comes on the profound global developmental delay. History of stiffness in both lower limbs since the age of 1 year, which was noticed during changing of cloths and diapers, and noted scissoring of legs, more pronounced during lifting and standing. Child is getting regular physiotherapy and occupational therapy daily in the morning for 2 hours. Child is interested in surrounding, recognizes family members, conveys inner needs through gestures and sounds. Sleep of child is normal, no behavioral disturbances in form of aggression and self-harm. Able to fix and follow objects, history of convergent squint in the right eye, no history of drooping of eyelids, able to appreciate the pain over face, no facial asymmetry while smiling or crying, able to close eyes fully, no drooling of saliva, regurgitation of feeds, no difficulty in neck movements, no deviation of tongue while protruding, and no history of involuntary movements. Able to hold the toys firmly, able to lift the arms above head, can't sit up from supine position on his own, able to lift lower limb against gravity, able to appreciate the pain during injection, bowel and bladder control not attained. History of frequent respiratory tract infections for which needed hospitalizations and IV medications, no history of constipation, no history of recurrent UTI, no history of fever with altered sensorium, no history of trauma, no history of recurrent vomiting, no abnormal urine order, no history of regression of milestones. Parents are aware of the chronic nature and prognosis of illness. They were regularly giving anti-epileptics and regular physiotherapy and occupational therapy. He needs support for his regular day-to-day activities. History of fever for last 7 days, insidious in all, which was intermittent in nature, not associated with tiger. Highest documented temperature is 1 or 2 degree Fahrenheit. No diurnal variation and subsiding with oral antipyretics and getting relieved of for 6 to 7 hours and recurring after that. History of cough for 7 days, insidious in onset, moist cough. Frequency and intensity of cough was increased for last 4 days and increased while on lying down, not associated with the fast breathing and increased work of breathing. Cough was relieved by giving oral medications. Immunization history, up to date as per IP schedule and annual flu vaccine given. Nutritional history based on 24 hours recall method, mixed diet, take solid foods, no swallowing difficulty, on regular multivitamin supplementation. Expected calories 1300 kilocalories, but intake is 800, deficit is 500 kilocalories of 38%. Expected protein intake is 19 gram, but intake is 14 gram, deficit is 5 gram. Family history is a non-consanguineous marriage. Twin 1, twin 2 is girl, active and healthy. Third child is boy, 8 months old, active and healthy. No history of similar complaints in the family members. Socioeconomic history, according to modified Kupaswamy scale, he belongs to the upper middle class. Summary, 4 years, 7 month old boy born out of non-consanguineous parents, IVF conception, twin 1 with significant perinatal history with global developmental delay and epilepsy and multiple anti-seizure medications, stiffness of both lower limbs, right eye squint with frequent episodes of respiratory tract infections on regular physiotherapy, or now with lower respiratory tract infection. I would like to think in terms of static encephalopathy, probably the cerebral palsy, and probably etiology with perinatal depression.
Can you hold, sir?
Prasanna, you start off. Yeah.
Okay. So, Madan, can you tell any points that has brought you to the conclusion that it is static encephalopathy 1, and any other points from the history, whether it is what type of cerebral palsy?
So it is a type of the spasticity, sir, because there is stiffness noted in the both lower limbs, sir. So it comes in the spastic type, sir.
Okay. So how will you assess from the history what type of cerebral palsy topographically, and whether it is spastic or atonic?
So from the history, we know.
Can you
able
give
to take
some clues?
Sir?
Can you ask for some clues from the mother?
Yes.
So,
well, sir, sorry, sir, I am not able to hear, sir.
so can you ask some clues from the mother whether it is what type of topographically, what type of cerebral palsy 1? Second, whether it is spastic or atonic, or what type of cerebral palsy?
So in spasticity, there may be the seizures will be there, sir. Seizures and involvement of the lower limbs and upper limbs. In spastic quadriplegia, there is involvement of both the upper limbs and lower limbs, sir. With the history, we are able to take how is the movements of the upper limbs and lower limbs. There any stiffness noted in the lower limbs and upper limbs.
Dr. Madan, what Prasanna sir is asking, from the delivery point of view, from the mother's history, could you assess it could be what type of cerebral palsy? Say one clue from the mother. See the gestational age. Will it be of any help to assess this child could be of this type of cerebral palsy? That's what sir is asking. That history will give you a clue.
So in prematurity and parental depressions,
that is a more important point.
So prematurity when the less than 37 weeks, are there any involvement of the difficult labor? Then
okay, can you go
parental
back
depression,
to your slides, history part? Can you go back to your slides? Can you go back? Yeah, please. Stop. Next slide. Next slide. Yeah. So previous slide. So from here, what are all the points that you get? So suppose if there is it is atonic or dystonic cerebral palsy. So what are all the clues you will get from here?
So in dystonia, that may be the twisting movements of the limbs, sir.
Okay, so we should ask for that history. Then
It's mostly present during it's increased during the handling, sir. Dystonia is mostly increased during the handling.
okay. So how
It's
will you
not
ask
present.
history for atonic cerebral palsy? Flaccid. If the child is flaccid, how will you ask history?
During lifting, well, the baby is slipping from the hands, sir.
Okay. So how old is he now?
So 4 years, 7 months, sir.
4 years. Usually by 6 months, 7 months, how the parents usually carry the child? They usually put the child on the hip. Okay, so whether the child is sleeping when the child is being carried on the hip, like இப்போ வீட்டிலலாம் குடத்தை எடுத்துட்டு போவாங்க அந்த மாதிரி குடத்தை எடுத்து போற மாதிரி தான் குழந்தை எடுத்துட்டு போவாங்க ஸோ அந்த மாதிரி ஏதாவது ஸ்லிப் ஆகுதா ஸோ that will give you a clue. Okay, you have rightly said that while changing the clothes, diapers, they have noticed the scissoring. So that is how we took it is going to be a spastic. Okay. So how did you get the clue that it is upper limb more than lower limb? Sir, when I was a PG, Dr. SB sir will tell you have to bring all the points of cerebral palsy. You have to bring sleep like you have done. You have to bring your constipation. You have to bring rickets. You have to bring all the problems of cerebral palsy inside your history. You should also ask what is the size of the head. So whether if the child, if the family has other kids, so they will ask. You should ask whether this kid has a smaller size at that time when compared to other kids. So you should try to bring all the problems. So you have. Can you go to the next slide? Next slide. So you have mentioned about involuntary movements. Any behavioral problems?
So no behavioral problems, sir.
Okay, so how will you ask history for
Prasanna,
behavior?
he mentioned that the sleep is okay, behavior is okay.
Behavior is okay. Okay. So like that, you try to put all the problems and then you try to put it in your summary. So you try to bring all this in your summary.
Okay, sir.
Okay. As Sir said, it is not. We are not going to. It is going to be a program where we learn from each other. So, sir, any other points you want to add, sir? SB, sir?
Yeah. First of all, the brilliant presentation. First, Madan, I must appreciate
Yes,
you. You have covered. In fact, you'll be surprised at my question. How much time you took to get history of this proportion? Please tell me, be honest.
So 50 minutes, sir. 50 to 1 hour.
Minutes. Yeah. In real life, you'll never get. In fact, in the exams also, you will not get. That's a problem. If you take too much time, sometimes you go out of focus. Okay, but brilliant. You have done a good job. But if I were to improve, my job is only to improve your history. Go back to the second slide. Go back to this first slide. Yeah, first slide. And let me improve it from. Let me try to improve it from the first slide. Now,
okay, sir.
The first slide. Yeah, chief complaints. Okay, you started with the statement that with the underlying history of developmental delay and epilepsy since 6 months of age. Okay.
Yes, sir.
Now, what do you mean by the term epilepsy? Why did you use the term epilepsy in this baby?
So more than 2 unprovoked seizures term as epilepsy.
No. You have said first statement. I said with underlying history of developmental delay and epilepsy. What do you mean by the term epilepsy?
So more than or equal to 2 unprovoked seizures.
Unprovoked seizures. You want to call this child as having epilepsy?
Yes, sir. Because there is multiple seizures is there, sir. Multiple episodes of seizure is there from
here. See, usually epilepsy is a term you use only after investigations and then only you give a label. You follow what I'm saying?
Okay.
Is So you
Yes,
should
sir.
avoid giving a label before you start your history. So
Okay,
that's
sir.
my comment number. For improvement, you should have said that since you don't have to see, it's always said, no, in Tamil they say if a father's house is raided by the CBI, the child was there in the drawing room, and when the policeman and the CBI came, the boy said, "My father is not hiding in the bathroom." Okay, like that, you don't know where to start. So you are trying to defend your antenatal history. So
Yes.
these sentences, like, for example, I would like to start with antenatal history, should be avoided. It gives an impression to the examiner that you're not very confident. Yes or no, Madan? You're not sure
Yes,
where
sir.
to start. Yes or no?
Yes, sir.
Yeah, that's what is called starting trouble. You should never have a starting trouble. In
Okay,
this
sir.
child who's now 4.5 years old, and who had problems in utero, there is a definite history. You need not make a statement. Should you have a doubt that this antenatal history is important or not?
It's
Do you
important,
have
sir.
a doubt?
No,
When
sir.
you're very confident that the problem had started right in the antenatal period, I don't think you should be making a statement saying that I would like to start somewhere. So in the exams, make it a point to start. But if the exam asks you, why did you start in the antenatal history? You must say, sir, this is a very relevant history. That's why I started. But never say
Okay,
I
sir.
started there. That is number 2.
Okay, sir.
The third is, you need not mention about the fever and cough in the beginning. If I were you, I would have started the statement because the major problems are neurological, the minor problems are respiratory. So I would have
Yes, sir.
started the presenting complaints as developmental delay, recurrent seizures, okay,
Okay, sir.
fever and cough for 7 days.
Okay, sir.
That's how I would have started instead of making such a confusing long statement, which can end up with more questions from the examiner. That's my comment number 1. Go to the next slide. Yeah. Now here again, in a long history, you must focus your attention on the most important areas. Let me ask you, Dr. Madan, where did the problem start for this baby? Did it start antenatally, or did it start perinatally, or did it start postnatally?
So antenatal it started, sir.
Antenatally. Which part of the antenatal period did the problem start?
Only the first time is also the IVF conception is also one of the reasons.
No. See, this child, you think it was because of IVF conception this baby developed all the problems?
No, sir. Pregnancy hypertension, sir. Pregnancy is hypertension.
Yeah. So now tell me, where did the problem start in the antenatal period?
Third trimester, sir.
Third trimester. So if I were you, I would have started the whole story from the third trimester, mentioning that first 2 trimesters were essentially uneventful.
Long.
You understand?
Okay. Yes, sir.
Always in the exam or in any presentation, you try to grasp the attention of the listener. For example, this slide doesn't contain any positive data except IVF. Yes or no?
Yes, sir.
Yeah. So you could have made it short after an uneventful first trimester. Go to the next slide.
Okay.
Go to the next slide. Yeah. And even uneventful second trimester. Yes or no?
Yes, sir.
Now, where should you have started? Go to the next slide. Yeah. This is where the problem started. This is where the problem. So you could have said this 29-year-old primigravida who underwent in vitro fertilization had a regular checkup during the first 2 trimesters, which are uneventful, developed pedal edema. You follow what I'm saying?
Yes, sir.
So, otherwise these three slides were a waste. You could have started here.
Okay, sir.
Here. And you know very well. But I didn't see anything about the weight gain of mother. Do you have any data?
No, sir, I'm not mentioning. I'm not asked that weight gains.
Okay, you should have asked. You should have asked about the weight gain in the mother. That's the only thing missing. Rest of the thing, folic acid, everything you have mentioned. And do you think this history is significant or not significant?
Significant, sir.
Significant. Okay, next slide.
Yes.
Next slide. Please go to the next slide. Now, born at 34 weeks, emergency LSC. What is the indication for the LSCS? You didn't mention.
So that
Was it a
uncontrolled
maternal
pH,
indication or was it a fetal indication? Or
maternal
both?
indication.
Ah,
Maternal
that you should
indication.
mention. That you should have mentioned, because if they had done an emergency LSCS because of some changes in the heart rate, okay, some findings in fetal ultrasound, that makes it different. Here, what is a maternal indication?
So uncontrolled pH, sir.
Ah, you should have mentioned that uncontrolled PAH led to an emergency LSCS. Okay,
Okay,
right,
sir.
right. And I'm sure the twin pregnancy was diagnosed right in the antenatal period. Yes or no?
Yes, sir.
So you could have mentioned that right in the antenatal history instead of bringing in the natal history.
Okay,
Okay, that again
okay, sir.
becomes another risk factor for HIE, isn't it? Right.
Yes, sir.
And what do you mean by baby not cried at birth, cried after initial resuscitation? Details not available.
Sir, immediately after the birth, baby is not cried, sir. Only after the initial stimulation, baby cried, sir.
No, the patient is the twin one or twin two?
Twin one, sir.
Twin one, twin one. How can you say details not available? Cesarean, institutional delivery. Okay.
Grandmother is not aware what they done for initial gestation, whether they give the stimulation or whether
Fine. Okay. Next thing is, after 1 week, he received the baby received oxygen for 1 week.
Yes, sir.
Yeah, that you could have mentioned. 1 week. What is the feeding? When did the baby start breastfeeding? When was the baby started on tube feed? Which day? By third day, you had mentioned. What about breastfeeding?
So they are not started on the breastfeed, sir, because mother has
Direct
insufficient milk.
direct breastfeeds.
Sir,
Direct breastfeeds.
they not started on the direct breastfeed, sir, because the
Okay.
mother doesn't
Okay.
have milk secretion, sir.
Okay, let me ask you a simple question. Do you think this infant suffered from hypoxic ischemic encephalopathy? Yes or no?
Yes, sir.
On what basis? What are the criteria to say an infant has had hypoxic ischemic encephalopathy or asphyxia neonatorum, old term? In the exam, I were to ask you, how will you definitely diagnose asphyxia neonatorum or HIE? What will be your answer?
So Abga scored more less than 3, sir. Less than 4.
Less than 4. Afghar at 1 minute. What time Abgar of 4? 1 minute Abgar. Okay. See, this is where we have moved forward from my student days. Okay. In my student days, it is only Abgar score which is used. Okay. Now you remember the criteria have changed. One is that the Abgar score less than 5 at 5 or 10 minutes. 5 and 10 minutes. That is one criteria. Second criteria, very objective criteria in modern neonatology days, modern perinatology days. Can anybody put it in the chat box? What's the correct answer? Is the fetal umbilical artery pH.
pH.
Okay, less than 7 or a base deficit 12 or more. Okay.
Okay,
Third,
sir.
clinical and neuroimaging evidence of early acute birth in brain injury, either with an MRI or clinical data like seizures, encephalopathy, ideally between 24 to 96 hours. This is the modern classification of modern criteria for diagnosis of HIE. Do you think this infant suffered from HIE? Yes or no?
Yes, sir. Yes, sir.
And what do you mean? Why do you say infant had HIE?
So because the baby needs initial registration for cry, so
No Abgar is available. No Abgar is available. Only respiratory distress.
Hello. So I'm not hearing.
Prasanna sir, I think sir has been disconnected.
Disconnected.
Yeah, I think. You can continue until sir comes.
Yeah, yes.
So I think sir was asking why without Abgar, how can you say that an Abgar or any other criteria, how can you say that this child had HI? Baby did not cry at birth only indicates a possible depression, perinatal depression does not necessarily indicate an
Maybe also respiratory distress also baby had, sir. So maybe needs
but
some
that doesn't fit.
supplementation.
See, but that doesn't
Hypoxemia.
fit into your. But that doesn't fit into your HIE. So that's exactly. Do you have those details? That's exactly what sir was asking, isn't it? That's now you
Yes,
can
sir.
continue.
Yes, sir. So, சொல்லுங்க மதன், நீங்க continue பண்ணுங்க.
Oops.
No, we'll wait for the next slide. On the slide, cut the slide. Sir was dissecting each slide. Go back to that slide. He'll join.
Sir, can I proceed with the examination on the slide, sir?
No, you go back to this IVF slide. Sir was
Oops.
dissecting each slide. IVF. Yeah. Next slide. Okay. So here you are telling after discharge he was well till 6 months of age. So
Yes, sir.
how did you say he was well till 6 months of age?
Because the child was alert and active, sir.
Okay.
No seizures episodes in the up to 6 months away. Taking feeds well and adequate weight gain is also there.
Okay. And the developmental milestones was normal till 6 months of age?
It's no, sir. Actually, there is a delay, but my grandmother didn't notice the delay, sir. Only after the neurologist said, only the grandmother is aware there is a delay.
Okay. So it was a problem with awareness, but there was definitely a delay.
Yes, sir.
Okay. So I think அது இன்னும் கொஞ்சம் வேற மாதிரி போடலாம் நீங்க. Maybe you can tell that the problem was noticed till from 6 months of age. So
Okay,
it
sir.
was identified from 6 months of age, or the problem was noticed from 6 months of age. Anmari. Okay.
Okay, sir.
Subbu sir, I think the participants level has reached 100. So sir may not be able to join back inside. I think sir has joined. Sir
has joined. Sir? Shall I exit so that sir can join in?
I'll ask sir once. He's not able to join because there are 100 participants. Sir. Priya, can you log out, Priya? Next slide. Sir is back. Can you move to the previous slide where sir left?
Yes, sir.
Welcome back, sir. Sorry for the trouble.
Yeah, sorry. It got disconnected. I don't know what's the problem.
Yes, sir. அதுக்கப்புறம் 100 people இருந்தனால உங்களால உள்ள வர முடியல. I'm sorry. I didn't realize only Prasanna with us. Thank you.
Yes, sir.
Okay. Now, the reason why I asked you this question, whether this infant had HIE or not, was because full details were not available. You never had any idea about the, what do you call, Apgar score. And though you had mentioned about, what you call, oxygen requirement, you did not mention anything about behavior of the baby. What was the sensorium of the baby? Encephalopathy history should have been obtained. I'm sure you would have obtained history if you go to the mother and ask again. The baby would have hardly had any cry in the first few days while being on oxygen and respiratory support, indicating that there is an encephalopathy. And you could have even inquired into investigations such as ultrasound, which could have given you a clue that something had gone wrong neurologically for this baby, suggesting that this baby had HIE. Okay, of course, expecting pH and expecting correct Apgar may be too much, but modern days you have to, in fact, you will be surprised to know that the American Academy of Pediatrics sat down with the American Academy of Obstetrics and Gynecology, changed the definition of HIE only to reduce the number of legal suits to pediatricians. Many a time, pediatricians were sued by parents for HIE, though the problems had started very much in the antenatal period. Okay? Okay, go to the next slide, please. Go to the next slide, please. Okay. Now, you have said that after discharge, he was well till 6 months of age. I'm afraid how you came to the conclusion that this infant was well till 6 months. What all questions did you ask to make sure that the infant was well till 6 months of age?
How is the feeding? How is the activity? Whether they moves all the limbs, whether they are aware of the surroundings, any social smile is there, weight gain.
You mean to say this baby had social smile at 6 weeks?
No, sir.
Did the baby have head control at 4 months?
No, sir.
Did the baby had hand grasp, active grasp at 5 to 6 months?
No, sir.
Did the baby start using AU, E, O at 3, 4, 5, 6 months?
No, sir.
Was the baby's tone normal?
No, sir. It's not
Was the
abnormal.
baby's posture normal?
No, sir. Posture is abnormal,
And
sir.
how can you say he was well till 6 months of age?
So,
So is
till 6
that
months
a
of
right
there is a
statement?
problem.
Is that a right statement, or is there something wrong with that statement?
So, there is a problem, sir, but grandmother is not aware of the problem, sir.
Grandmother is not aware, but if you ask her, she will tell you. She has not attended CMEs to tell you whether the baby is developmentally normal or not. You should have asked questions. You cannot make a statement that the infant was well till 6 months of age, because if what you are saying is true, is your diagnosis of cerebral palsy right or wrong?
So, right, sir.
Huh? How can you say right? How can you see? How can the baby be completely normal till 6 months? Then, if that is the case, I would have started thinking of a neuroregression. Okay, because the whole thing starts 6 months completely normal infant, baby starts getting seizures, then the baby is found to have a spasticity. This could well be a degenerative disease. Is this a degenerative disease or a static encephalopathy?
Static encephalopathy, sir.
Then how do you say it was normal till 6 months of age?
Yes, sir.
Okay. Anyway, so don't get rattled. This is the way we question in the exams also. See, your statement that it was normal till 6 months is wrong. In fact, most of the time, the students always say that infant is normal at 6 months. I'm sure it was never normal. Even in the newborn period, you could, if you go back and ask the mother would have told you, doctor, the baby hardly cried. The baby hardly had any spontaneous movements. And 6 weeks, 10 weeks, 14 weeks vaccination, the mother would have said the baby was crying very poorly. There was no social smile, etc. Okay, that you
Okay,
could have
sir.
gone into details. Okay, then seizure started at 6 months. Please go to the next slide. So, and here again, 1 minute, please go to the previous slide. You are mentioning MRI brain was set. So at 6 months, when was the developmental delay noted?
It's around 7 months, sir.
7 months, 7 months, 7 months. How can you say developmental delay if everything had been normal at 6 months? That is my question. Okay. So there's something wrong. You could have corrected it, mentioning that
Okay, sir.
everything was abnormal right from birth. Okay. Please go to the next
Okay,
slide.
sir.
Next slide. Okay. Physiotherapy. Okay. Next slide. Next slide. Okay. And you rightly, I mean, your developmental history was perfect in the sense that everything had been delayed. All the domains are delayed. And I'm happy that, you know, that you, please go to the next slide. Please go to the next slide. Next slide. Yeah. I'm happy. Go to the next slide. Yeah. You had very clearly mentioned that there is no behavior disturbance, sleep is normal, and you had mentioned that there is a global developmental delay. Okay.
Yes, sir.
And here again, you are mentioning that the stiffness started at 1 year. Do you think it was right?
No, sir. We started early, sir.
No, it started
We
early.
started the early, sir, but noted by the grandmother is by around 1 year, sir.
Okay. But mother noted by the grandmother. But grandmother, if you question her, she will tell you everything was delayed, man. This note she might have noticed, but you could have always got the history. Okay. Right. Go to the
Okay,
next.
sir.
Go to the next slide. Yeah. Okay, fine. All negative history. And in fact, I don't think I would have asked history of facial asymmetry. Did you expect facial palsy in a child who has got problems like this?
No, sir.
Yeah. So I don't think it is relevant. Try to avoid all these what I call as a negative exuberance. Next slide. Okay. Next slide. What do you mean by bowel and bladder? Please go back. Go back. Yeah, bowel and bladder control not attained 4 years. What is the milestone that you will expect with regard to bladder in a 4-year-old child, in regard to bowel in a 4-year-old child? Tell me the normal course of development of bowel and bladder control in a normal child.
So initially, the bladder control should attain up to 2 years, sir, and the bowel control is attain 4 years of age, sir.
Which
So
one
after
comes
4 years,
early? Which one comes early?
bladder, sir.
No.
Bowel.
It's the other way. Actually, it is the bowel control which comes
Bowel
early, not the bladder control. Okay. In fact,
Okay,
bladder
sir.
control, you know, you are allowing enuresis up to 5 years of age. Okay. You are allowing enuresis up to 5 years of age. It is a bowel control which starts even by 1 year. The baby will start indicating the moment it has passed stools in the diaper, discomfort. Okay. And 1 to 2 years, by 2 to 3 years, bowel control will get firmly established. Only bladder control takes a longer time. Okay. Next one.
Okay, sir.
Next one. Okay. Next one. Now, you have mentioned so many things related to development. What about the growth of the child from the history? Is it important to ask yes or no?
Yes, sir.
What growth history should you have obtained in this child? And how is that relevant to this case? You could have even made a diagnosis.
Weight gain, sir.
One is weight gain. How is weight gain important in a child who has got developmental delay?
The wasting of muscle is there.
That has nothing to do with weight gain. Baby can be obese, can still have wasting of muscle.
Nutrition and feeding, sir. How is the feeding difficulties
feeding.
there?
For example, if there is a quadriplegic child, definitely it will fail to thrive. A hemiplegic or a diplegic child is very, very unusual to have failure to thrive. In fact, in the absence of normal locomotion, many of these cerebral palsy children tend to become obese. Okay, that is one. Second, only weight is important. In this child, I would have obtained some more history regarding growth. Can anybody put in the chat box what it is? What parameter you should have obtained? Head size. Is it crucial, Madan?
Yes, sir.
In what way? What way head size would have given you some clue to the entire problem?
So microcephaly is there or not? There is
Excellent,
torch
excellent.
infections.
Microcephaly, in what way it would have helped you? Tell me.
Antenatal infections is
Excellent, excellent. Now, two things. I would have definitely inquired into the head size of the baby. Not only the present head size, I would have asked the mother and the grandmother, how was the head size at birth? Why is that important, Dr. Mother?
so again the torch infection. If the torch infection is there, means the microcephaly will be there, sir. Or any syndromic baby.
Two things. A head size which is abnormal, which is low right at birth, indicate that whatever insult that is responsible for the microcephaly had taken place in the antenatal period in utero. Whereas if a mother comes and tells you, doctor, my baby's head size was completely normal at birth, but then at 2 years, the baby's head size was small, it becomes a different story. The insult probably took place in the neonatal period or later. So the timing, in fact, I would have gone into this. And in this infant, I am sure the mother would have given you a history that the head size was low. And more importantly, in a child who is spastic, who has got spasticity of both the lower limbs and who has got delayed development, and in whom you had mentioned everything was normal for the first 6 months, tell me what head size history would have helped you make a diagnosis? Large head. A large head from birth or increasing head size from birth would have given a clue that this is either a hydrocephalus which is responsible for the spasticity, behaving like a CP, or this is a megalencephaly secondary to a white matter degenerative disease which is mimicking a cerebral palsy. For example, the most notorious white matter disease which resembles cerebral palsy is your metachromatic leukodystrophy. And the metachromatic leukodystrophy, the head size is usually large. Megalencephaly may be there. Okay, so do not forget the head size, do not forget the length. But even the length is important. It's very unusual for any growth retardation in height in babies who have diplegia or hemiplegia. It may occur with quadriplegia, it doesn't occur with hemiplegia or diplegia, right? Short stature, you have to think of alternative diagnosis also, right? Okay.
Okay, sir.
Next slide. Next, then you mentioned about fever, agreed. Next slide. Okay, cough, no, not for LRI. Okay, next slide. Next slide. Up to schedule, immunization, fine. Immunization, fine. Go ahead. Go ahead. Go to the next slide. Okay, nutrition, of course, here, since the infant is getting nearly about, only about 75% of the calories and, not even 75, so about 60% of the calories and 60% of proteins, 70% of the proteins. I would have gone more into detail. You should have mentioned something about breastfeeding, because whether there is any difficulty in breastfeeding in the early days. Right, next. Family history. Okay, the other twin is completely normal. Am I right?
Yes, sir.
Development. That is very, very important. Which was the first twin? This is the first twin. What is the meaning of twin 1 and twin 2? This is a cesarean section, isn't it?
Yes, sir.
Suppose it's a vaginal delivery of twins. Which twin do you call as twin 1 and which twin do you call it as twin 2?
The baby which delivered first, sir. It's a twin one.
One which comes out first is the second twin, and the one which comes out second is the first twin. I don't know. Okay, that's what the gynecologists say. The one which comes out late is the first twin, not the one which comes out first if it is a vaginal delivery. Right? Okay. Next. Okay, now go to the summary of the history. Okay, now in the summary, you said that there is global developmental delay. In fact, you could have actually added one more adjective to that. What adjective would have helped you? Symmetrical global developmental delay. That is, see, you can have global developmental delay with some discordance. For example, you may have developmental delay with more of motor involvement and less of cognitive involvement. Or you may have development delay with more of cognitive involvement and less of motor involvement, vice versa. Both can occur. So you could have mentioned, was this symmetrical global development delay or discordant? Was it symmetrical or global?
Symmetrical.
Okay. Epilepsy, again, I would not have used the term epilepsy, recurrent seizures, right? Instead of using a term epilepsy, stiffness of both lower limbs. And again, if you had mentioned something about stiffness, you should have mentioned what was the posture of the baby. Could have even inquired into scissoring from the history, right? Right eye squint, frequent episodes. What do you mean by frequent respiratory infection? What is a frequent?
6 to 8 episodes in a year, sir.
What, URI, running nose?
So URI, sir.
URI, 6 URIs, you call it as recurrent. Almost 100% of Indian children will have recurrent RTI, as per your definition. Actually, it is not so. You must have, LRTI. You must have only LRTI 6 times, not simple URI. But Andrew Bush says 15 respiratory infections per year, 15 days of symptoms. If the child's growth is normal, development is normal, you don't call it as recurrent RTI. It's a normal child. URI is not recurrent respiratory infection, right? On regular physiotherapy, now with lower respiratory, in terms of static encephalopathy, probably cerebral palsy and probable etiology. Okay, fair enough. Prasanna, you want to ask some more questions before we move to the physical findings? Sorry, my internet got disconnected. I was not there for 10. Prasanna, you want to add something?
Sir, that's what, sir. I asked them whether he said till 6 months child was well. So that was one point which was not fitting in. So that's what I said, sir.
Okay.
Can we proceed with the examination, sir?
Yes, please. Sorry. We are already 9:10. Please go ahead. Sorry.
Yes, sir.
The general examination, the child awake, alert, comfortable in the bed, IV cannula on the left hand, looking around, pallor plus, no interest, no clubbing, no perial edema, no significant lymphadenopathy.
Madan, examination. Pictures, 1 minute, you have the pictures with permission of the parents of the child by any chance?
No, sir, I don't have any pictures, sir.
Okay, doesn't matter. Okay, now if that is so, one suggestion to Madan and the young postgraduates listening to the webinar. Pediatricians, are smart guys. They usually are like Sherlock Holmes. They look for clues right from the time they have a first casual look at the infant, casual look at the child, casual look at the mother. So that way, your general examination should always start with some statements on the general condition of the child. The first question I would ask, is this child sick or not sick? Is it ill-looking or well-looking, Dr. Madan?
It's well-looking child.
Well-looking. Okay, that is how I would have started. This is a well-looking 4-year-old child. Okay, and if it is ill-looking, I would add an adjective, whether it is acutely ill-looking or chronically ill-looking. That's how I would start. Second is that, of course, awake, alert, comfortable, and looking around. And one more statement I would have added, whether it was easy for you to examine or difficult for you to examine. Was it easy for you to examine or difficult for you to examine?
Easy for the exam, sir.
Pardon?
It's easy for examination.
Easy for examination. No obvious discomfort made. And yes, then you are paler, icterus, etc., etc. Paler plus, okay, etc., etc. Okay? Right, go ahead.
Head-to-toe examination. Head size appears small and elongated. Hair normal.
If I were you, I would have made a statement on the head size right in the previous paragraph. I said the child appears to have a small head. In fact, whatever that you are making out at the first cursory look, you should always bring to the attention of the examiner. Please go ahead.
Hair normal, flat, aspect, no edging of sutures, right convergent squint, no cataractosis, no dysmorphic features, oral cavity normal, chest normal, abdomen normal, upper limbs normal, wasting of muscles in both lower limbs, scissoring of the lower limbs present, and bilateral ankle contracture is present. Genitals normal, no kyphosis scoliosis, no neurocutaneous markers, no bed sores. Vitals, temperature is normal, heart rate and vitals is hemodynamically stable, sir. Anthropometry, expected weight 16 kg is observed at 12.7 kgs. It comes under less than third centile and -2 to -3 standard deviation is grade 1 malnutrition. And segmental length expected 110 centimeters, observed 100 at third to 15th centile. It comes in 0 to -2 standard deviation. Head circumference is observed is 47 centimeters, less than third centile comes microcephaly. Mid-arm circumference 14.5 centimeters normal, and weight for length is below third centile. It comes in failure to thrive.
Okay.
CNS examination, higher
I'm
mental
happy.
function,
Two
child
things.
is
Two things. I'm happy. Please go to the previous slide. I'm happy you didn't say that this is protein energy malnutrition. This is not a nutritional problem. This is actually a systemic problem which is responsible for the poor weight gain. And the weight is more affected than the height. The head circumference is obviously abnormal, right? Okay, go ahead.
higher mental function, child is awake, interested in surroundings, eye contact present, recognizes the grandmother and sisters, is makes sounds and right-handedness. Cranial nerve examination, first nerve is not tested, second nerve fixes and follows objects, third, fourth and sixth nerve, EOM extraocular movements are full, right convergence spin presence, pupil size is equal, no nystagmus and direct and indirect reflexes presence. Fifth nerve, corneal and conjunctival reflex presence and sensation over the face normal. Seventh nerve, no facial asymmetry, no deviation of the angle of the mouth. Eighth nerve turns to sounds, names and when called. Ninth and 10th nerve, exaggerated gag reflex presence, no drooling, no difficulty in swallowing. 11th nerve, moves side to side. And 12th nerve, bulk normal, no atrophy, no fasciculation. Motor system examination.
1 minute, please go to the cranial. Other than the squint, non-paralytic squint, you didn't make out anything in the cranial nerves. What about the fundus?
I couldn't even examine the fundus, sir. Sorry.
Please, in the exam, even if you are not able to examine, I attempted, I would like to dilate and see. But many examiners will definitely ask you why you didn't see, because fundus may be something which is very crucial in the diagnosis. Okay. Okay. Let me ask you a question, exam question to you. How will fundus examination help in a child who has some encephalopathy like this, static encephalopathy like this, in terms of diagnosis?
So to look for any cherry red spots and chorioretinitis.
Your diagnosis itself may be wrong. You may get a clue to the degenerative disease in the form of retinitis pigmentosa or a cherry red spot. If it is cherry red spot, it could mean a gangliosidosis or a white matter degenerative disease. If it's a retinitis pigmentosa, it will give you a clue. It's a gray matter degenerative disease, right? If there is chorioretinitis, you can get a clue to the intrauterine infection. Okay, if there is cataract, again, you can make out by looking at the fundus, right? So you should mention that you attempted at least the fundus examination. Go ahead.
Okay, sir. Motor system examinations, bulk, no asymmetry, wasting of muscles presence in the both lower limbs, and tone inspection, upper limb moving the both upper limbs in all the directions, and lower limb extended, internally rotated at the both hip, partial flexion at the both knee joints, and bilateral plantar flexion. Palpation of the tone, right side upper limb in the both sides normal, and lower limb is hypertonia on the right side and hypertonia in the left side, sir. Flappability, the movements reduced in the ankle joints bilaterally, and bilateral dynamic ankle contracture is present. Power is around the both upper limbs is 3/5, and the lower limbs is a 3/5, sir.
I'm surprised. It's 3/5 in the upper limb, but unfortunately we can't verify. I mean, if this is true, it looks like more of quadriplegia than a diplegia. It's okay, fine. We can't verify now. What was the posture of the upper limb? Was it pronated or was it supinated?
So it's supinated only, sir.
Supinated. What about the thumb? Was there a cortical thumb with the thumb flexed into the palm?
No, sir. Thumb is normal. No cortical thumb is present, sir.
Then I would be surprised if it is 3/5. It should be 4/5 in the upper limb. Were the spontaneous movements better in the upper limbs or lower limbs?
So better in the upper limb, sir.
Then how can it be 3/5 in the upper limb?
I'm not able to test the against the resistance in this child, sir.
But even if you can't test, while testing the power in the upper and lower limbs, did you feel that the upper limbs are better than lower limb? Yes or no?
Yes, sir.
Then if I were you, I would have intelligently put the upper limb power as grade 3/5 or 4/5 instead of 3/5. Okay, go ahead.
Okay. Superficial reflexes, corneal reflexes present, conjunctival reflexes present, abdominal reflexes present, and cremastic reflexes are present. Plantar reflexes bilateral extensor. Deep tendon reflexes, bicep juts 3+ in both upper limbs and triceps 3+ in both upper limbs. Supinator juts 3+ in the both upper limbs and knee juts 3+ in both lower limbs and ankle jut 4 clonus present in both the lower limbs.
Now here you get the clue that the lower limbs are more spastic than upper limbs. Yes or no?
Yes, sir.
Because you have got clonus and you put, the reflexes are more brisk in the lower limb than in the upper limb. Yes or no?
Yes, sir.
Yeah, okay, fine.
Cerebral signs, no nystagmus and others couldn't be elicited, and no signs of meningeal irritation, spine normal, autonomic system no flushing and no excess sweating, sir.
Wait. In the neurological examination, did you find any signs of dystonia? And what did what did you look for? Did you look for any evidence of dystonia?
There is any twisting of movements during handling?
What are the clues to the presence of, of course, this is spastic child. In a child with spasticity, how do you look for clues to the presence of a comorbid dystonic cerebral palsy also?
So it's present during the spasticity is present only during the sleep side, not present during the sleep.
The most
dystonia.
important clue.
During handling, the dystonic movements is most, sir.
The most important clue is the posture of the infant. Posture of the infant. If you find that the child has, sorry, not the infant, of the child. In this case, it's a 4-year-old child. If there is dystonia, the most important clues you would have obtained on physical examination would have been a bit of opisthotonus, would have been a bit of neck retraction, would have been a bit of pronation of the upper limbs, particularly during examination. The baby may go into an opistotonic posture, indicating that there is some dystonia. The very term dystonia means abnormality of the tone of the axial muscles. You could have definitely appreciated that if there had been dystonia. Had there been some, are there some signs of dystonia in this child or not?
No signs of dystonia, sir.
No, okay, fine. Go ahead. Right. Go ahead.
Developmental assessment, gross motor stands with support, fine motor pencil glass present, personal and social stranger answer is present, speech 1 to 2 words, mean. Other system examinations, CVC is normal and RS, there is scattered plus presence bilaterally and abdomen normal, sir. Final diagnosis, central motor dysfunction, spastic diplegia, global developmental delay, probably with normal vision, hearing with epilepsy, microcephaly, right eye convergent squint, bilateral ankle dynamic contractures with failure to thrive, with lower respiratory tract infections, with functional grade of gross motor function classification system 5, and probably due to prematurity and perinatal depression.
Prasanna, you can take over. Prasanna? Yes, yeah, you can take over. I'll come in late. Yeah, go ahead.
Yes, sir. So, Madan, could you please tell how you arrived at this diagnosis? What are all the points with which you arrived at this diagnosis? Clinical points. Can you hear?
Yes, sir. The stiffness is there.
Central motor dysfunction with the spastic diplegia. So,
yes,
so iroda number preferable or one thing which we can usually say is before telling the confirmed diagnosis, I am dealing a child with upper motor neuron lesion or a lower motor neuron lesion. And ஒரு umbrella term சொல்லிட்டு அதுக்கப்புறம் will come usually at the diagnosis. So what made you to come to this diagnosis? Can you tell the points that made you to come to this diagnosis?
So first, this seizure is there's multiples of seizures and the stiffness noted in the both lower limbs, and then global and the developmental delay. Then involvement of the lower limbs is more than the upper limbs, sir.
Okay. So, when will you say that the child has upper motor neuron lesion?
So whenever there is a seizure and global development and developmental delay and behavioral abnormalities.
The upper motor neuron lesion. Most important characteristic points that you say that the child has upper motor neuron lesion.
Seizures, sir. Seizures and developmental delay.
UMN को LMN को எப்படி நம்ம usually differentiate பண்ணுவோம்?
So UMN is where we increase in the tone and spasticity will be there.
Okay.
And in the element that is the digit and low tone and the reflexes are diminished, sir.
Okay. So tone, power, reflexes, then your whether the
developmental delay and
plantar clonus. So
yes,
other chis
the plantar mostly in the human is extensor, sir. And clonus is exaggerated reflexes present in the human.
Okay.
Clonus is present in the human. So element there is no clonus. Reflexes are diminished.
So in a number child, how we came at the diagnosis?
Here there is a tone hypertonia is there. Hypertonia and exaggerated reflexes. Clonus is also is there.
Okay.
So I come to it's a human lesion.
It is a central motor dysfunction. Okay. Okay, sir. Sir, you take over. Sir.
Yeah, Dr. Madan.
Yes, sir.
In addition to all the points mentioned by you and Dr. Prasanna, which starts with, spasticity, right? And
yes,
exaggerated tendon reflexes, clonus, okay, etc.
Okay,
there are two other features which differentiate an upper motor neuron lesion from a lower motor neuron lesion. One is that any upper motor neuron lesion is paralysis or paresis of a movement. On the other hand, any lower motor neuron lesion is a paralysis or paresis of a muscle or a neuron. You follow what I'm saying? For example, in the upper, we always have flexor hypertonia of the upper limbs and extensor hypertonia of the lower limbs in upper motor neuron lesion. Okay. So it's always a paralysis of movement. Entire movement will be affected, not a single muscle. That is upper motor neuron lesion. Second, any upper motor neuron lesion will always affect the dexterity of an individual movement. For example, something which requires, buttoning. Okay, something which requires threading. They are all fine movements, and without upper motor neuron lesion, without cortex, you cannot do that. Right?
Okay, sir.
Right? These are two important differences other than whatever we normally talk about when we try to differentiate an upper motor neuron lesion and a lower motor neuron lesion. Okay, go ahead, Prasanna. Hello?
Yes, sir.
Go ahead. Now,
can you go to your
before if you are the primary if you had been the primary pediatrician for this child who's now 4 years, would you have diagnosed cerebral palsy, say at 6 months or 1 year? Answer should be yes or no.
Yes, sir.
Would you have diagnosed cerebral palsy at 6 months or 1 year?
Yes, sir.
Yes, sir. Okay. Now tell me, what are the early signs of cerebral palsy in infancy, which should make you suspect that this infant could be having cerebral palsy? What are the clues? What are the signs?
So persistent of the Moro reflex and early handedness.
What do you mean by the term early handedness? What is early handedness?
Mostly the handedness occur only by 2 to 3 years of age, sir. If it occur less than 1 year of age, means it is early handedness, sir.
Excellent, excellent. Most handedness develops by 1.5 to 2 years of age. And premature handedness is defined as handedness developing before 1 year. Agreed. That is one. Two,
Fisting, sir. Persistent fisting.
persistent
Fisting of the hand.
fisting. What do you mean by the term first? Beyond what age is fisting abnormal?
More than above the 2 months of age, sir.
About 2 months. No. Up to 4 months. 4 months. Okay. Generally, the hand opens out by anywhere between 4 to 6 months of age. Okay. In fact, you can give even allowance up to 6 months for fisting. Okay, that is number 2. 3. Any other clues? Okay, there are a umpteen number of clues in this. This is a frequent
persistent Moro reflex, sir.
Persistent Moro reflex. Okay. Any primitive reflex which is persisting. Okay. Now, for the sake of saving time, I'll quickly run through the early signs, which I'm very fond of asking in the exam. See, any infant who feels stiff or floppy, both, you should start suspecting cerebral palsy. In fact, Illingworth, in his book, he writes, cerebral palsy is notorious for changing tone. In fact, if you had gone into the history of this infant, the grandmother would tell you that the baby was like Solakal Bommai in the first month, hardly moving and it was floppy. Whereas the same baby would have become dystonic or spastic by 6 months to 1 year. And many babies who suffer from severe HIE, the first few months they may be hypertonic. The next few months they may become dystonic. Toward the end of the first year, they become spastic. And cerebral palsy is considered as a disease characterized by changes in tone. That is 3. 4, whenever you lift the baby, young baby, say 6 months to 1 year, like this, and you find that both the shoulders are coming in and the baby's upper limbs are getting pronated and the lower limbs are scissoring, that is cerebral palsy for you, in all probability. Early scissoring, right? More importantly, in a young infant, 3 to 6 months of age, the head may fall back when you pick up the baby while lying on the bed. Pulling to sit, the baby's head may fall back. It may not come with the neck. After 6 months, failure to roll over and failure to bring both the hands together and absence of hand to mouth behavior. Okay. And you find that the baby, while it is in the supine position, it is only having cycling movements of one half of the body. It could be hemiplegia on the other side. And again, after 10 months, if the baby does not crawl on all 4 limbs, you should start suspecting cerebral palsy. In addition to all this, any absence of social smile, even at 4 to 6 months, delay in language development, small head, okay, mother saying she is unable to clean the diaper area because of stiffness, she is not able to stretch the thighs due to adductor hypertonia, you should always think of a cerebral palsy. These are all some very important clues to cerebral palsy early in life. Okay?
Okay, sir.
My next question, why not this be a neurodegenerative disease? I'm saying, you're saying first 6 months, everything is okay. So I'm saying this is a neurodegenerative disease.
There's no regression of the milestones.
Pardon?
No regression of the attained milestones, sir.
No regression. You said everything was normal up to first 6 months. You said everything is normal up to 6 months. Okay. Now, always you must remember, cerebral palsy itself can give you a clinical picture that it could be a degenerative disease. Can you answer my question? When does a cerebral palsy behave almost like a neuroregression? Can you give a few examples of classic cerebral palsy, but a clinician starts suspecting neuroregression? Can you give a few situations? Okay. Now, sometimes cerebral palsy may mimic a degenerative disease when there are uncontrolled seizures in the baby, it may behave like you may start thinking of a neuroregression or a neurodegenerative disease. 2, when orthopedic contractures become worse with the baby who was initially able to move the legs due to increased adductor spasm, is not able to move at all, then you start thinking of a degenerative disease. 3, when a child with cerebral palsy also has got a hydrocephalus, spasticity may worsen. It may behave like a degenerative disease. 4, intercurrent illness. For example, an acute illness with hypoxia in a child with cerebral palsy, the baby will become more drowsy. You will start thinking of neuroregression. 5, sometimes mothers, over-anxious mothers, may always tell you child is not improving, child is not improving, child is not improving. And it may not improve because of worsening orthopedic contractures. For example, worsening orthopedic contractures may not be always preventable. And you may start thinking of degenerative disease. These are the 5 situations in which you may start thinking it is not cerebral palsy. Okay.
Okay,
Now,
sir.
what are the most common differential diagnoses for cerebral palsy? Common differential diagnosis.
Maybe
Can you give a
Arjuni's
few examples of cerebral palsy mimics?
Arjuni's deficiency.
Pardon?
Arjuni's deficiency, sir.
I don't understand what you're saying.
So Arjuni's deficiency, metachromatic leukodystrophy.
Okay. Metachromatic, closest. See, depending on the type of cerebral palsy, your differential diagnosis may vary. For example, if there is spasticity, okay,
Yes,
you may
sir.
start suspecting that it may be metachromatic leukodystrophy. And metachromatic leukodystrophy may have a large head, may have spasticity, which is obvious only in the second year of life. Okay. The only difference is that you may pick it up with the cherry red spot, you may pick it up with the higher protein in the CSF, and of course, pick it up with the MRI. Okay. Whenever you have any of the following clues, to save time, I will just run through the clues. 1, if there is no obvious history of any perinatal risk factor for brain injury, like in this case, everything had been smooth, you always start thinking beyond cerebral palsy. Everything had been normal in the antenatal period, postnatal period, but the child has features suggesting cerebral palsy. You have to question your diagnosis. Second, if there is a family history of a sibling with very similar neurological symptoms, you have to think beyond cerebral palsy. Third, like what you said, first 6 months, everything has been normal. Then only everything had started becoming abnormal. So initial period of normal development with motor symptoms starting later is again cerebral palsy. Fourth, any regression. When you say regression, you have to have the criteria for 3 criteria for regression. To save time, I will tell you what are the criteria. 1, there should have been some period of normal development before regression starts. 2, whatever that takes place in terms of neurological deficit, it should persist for 3 months. Third, okay, whatever that is happening is not due to an acute intracranial infection, for example, pyogenic meningitis, tuberculosis meningitis, or a near drowning or child abuse. These are the 3 criteria to say a child has got a developmental regression. If regression is there, it is not cerebral palsy. Progressive neurological symptoms are there, it is not cerebral palsy.
Okay,
and
sir.
2 or 3 more points. Only ataxia, nothing else is there. Tone is normal, everything is normal, only ataxia. It's not likely to be cerebral palsy. Okay. Failure
Okay,
to
sir.
thrive. except in quadriplegic CP is unusual. Absent reflexes and sensory loss, no CP, right? And
Okay, sir.
last but not the least, only hypotonia, isolated generalized hypotonia. In fact, earlier days when we were students there, Nelson also used to mention what is called atonic diplegia, hypotonic CP with brisk reflexes. That is not an entity described in cerebral palsy. Okay. And my last
Okay, sir.
question before I hand over to Prasanna. Well, how do you classify cerebral palsy in modern days? What is the recent classification and which classification does this child belong to? That's my last question for you.
So spasticity, dystonia, and ataxia, sir. Spasticity comes in unilateral and
what is the classification?
So spasticity, dystonia, and ataxia.
Ataxia. Can you define the classification further? How is
Spasticity
spasticity classified as today?
unilateral and bilateral, sir. And
Excellent. The current classification is not based on diplegia, quadriplegia, hemiplegia, monoplegia, triplegia. The current classification has only 3 types: spastic, dystonic, and ataxic. And spastic is divided into unilateral and bilateral. That's all. And this will become spastic, bilateral or unilateral?
it becomes this bilateral, sir. Spastic bilateral.
This is spastic bilateral, primarily involving the
Lower
lower
limbs.
limbs. And this, in earlier days, you would have called it as this spastic diplegia.
Bilateral.
Not use the term diplegia today. It's only spastic bilateral cerebral palsy. Okay. Prasanna, quickly run through the management and finish it off. Thank you.
Madan,
Yes, sir.
how will you manage this child?
Sir, initially we would take the EEG, sir. EEG and look for any seizures. And
Okay.
before that, we have to look for any currently infection is there, so look for the total counts.
Okay.
Any infection is there, and then the EEG for look for the seizures, and MRI brain to look for any structural abnormalities is there itself.
Okay.
And management is mostly the multidisciplinary approach, sir. So involvement of the speech therapy, occupational therapy,
Okay.
physiotherapy,
Okay.
and there is a spasticity also is there. So the involvement of the orthopedician is also important.
So whenever in the exam, if you say the management, you first start like this. You tell them that I will review what all has been done. So what all has been already done to the child. So yours is a tertiary care center. So they would have done all the investigations previously. So I will review all the investigations previously. So I will see what has been already done to the child. Then, as you said, we can treat the current problem, acute problem. Then you come to the chronic problem, and then you involve a multidisciplinary team. So with the functional grade of 5, so we may need to give adequate support for this child. You involve so many people. Our President Somasundaram sir is also there. So we should take his help also. So that's how you have to say the answer. You don't just jump into, as you said everything correct, but we don't just jump into the management. You just say that I will review, then you see the acute problems, then you sort out the chronic problems, like you said. Okay. And any preventive aspects, if there is anything preventive here for the next child, so then that also you have to bring it. So I will involve the genitals. So all these points you have to bring in. Anything else to add?
No, that should be fine. If there are any questions in the chat box, we can take it up. Or if Madan has got any questions to us, no problem. Anything in the chat?
If I may add one more point, sir, while management of cerebral palsy, if we can insist on hip screening for all children with cerebral palsy, even during our teaching program, it might be a good help for children with cerebral palsy. That is one awareness that is important to be created among pediatricians and orthopedicians. Hip screening. Children with cerebral palsy have an abnormal tone around the hip joint, causing the hip joint to progressively migrate, the head of the femur to progressively migrate out of the acetabulum, causing hip dislocation in older children. And that is quite painful and needs surgical management. So that could be very much prevented by appropriate screening right from 2 years of age. And there is a specific protocol for it. And if that could be included as part of management protocol, preventive protocol, regular hip screening once in 2 years or once in a year, depending on the need of the child, that could also be added as part of the management, which every pediatrician can be part of.
Excellent point. Very excellent point. Very well said. In fact, the components of cerebral palsy care consists of taking care of movement, posture, mobility, communication, comorbidities, activity of daily living, care, comfort, quality of life, and not the least important, counseling of the family. I mean, this has been very well said by our friend. It contains so many components. It's not enough if we simply make a diagnosis, prescribe diazepam or some muscle relaxant or some anticonvulsants. It's not enough. You have to take care of everything. And, time is not far off when we'll have more focused therapies for cerebral palsy. Already we have a lot of medications to improve the tone. And, we can take care of the tone by physiotherapy, by drugs, by, so many intrathecal pumps, so many modern surgeries. I'm not going to waste time on rhizotomy and deep brain stimulation and so many things. And last but not the least, which is being talked about in the literature, is stem cell therapy. New drugs will soon be found out. And now they are even detecting in nearly 30% of so-called cerebral palsies, they identify genetic abnormalities. Days won't be far off and we'll be identifying minor metabolic defects in many of these so-called genetic CPs, and we'll be treating them, we'll be curing them, we'll be making them all right. The fight is on. And I'm sure we'll have a multi-component CP care with focus on all these areas to make their lives and the parents' lives much more happy than what it is right now. Yes, Prasanna.
Thank you, sir. Thank you. Actually, I wanted to tell one thing, sir. When I was a PG, you arranged a conference, CME. So there you made us all present to very stalwarts. I still remember I presented to Dr. Elizabeth Madam, a nutrition case. That time my heart was pumping. I was thinking, why sir is making to do all this? Sir, no. First I said no. You said that you have to do it. So similarly, that was a very eye-opener for all of us in our batch. Sir, our batch Manikumar. So most of them are nephrologists, neonatologists. So likewise, Madan, you will definitely do well in your DNB exam. I'm sure with the sir's words, wisdom. Again, sir gave one more shock. He said, you start the proceeding today. After a long time, again, sir gave one more shock. So here the audience is for you, sir. So that's why
Madan, please stop sharing. Madan, please stop sharing. Please stop sharing. Close your slides. Madan?
Yes, sir.
Yeah, Prasanna, go ahead.
So I'm sure this will be one big stepping stone for you, Mother. You did very well. In very short notice, you did a very good presentation. This is how the discussion in the DNB exam, it is not going to be the diagnosis that is going to be mattered. So it is how we discuss the case with the examiner. I still remember I said to the examiner that this child has post-meningitic sequelae. So the examiner said, no, this child, very famous neonatologist from Delhi. So the examiner said, no, this is not post-meningitic sequelae. This is meningitis. This is chronic meningitis, he told. I said, sir, no. This is a very reputed hospital in Bangalore. So if this is a chronic meningitis, then the line would not have removed and the antibiotic would not have stopped some 5 days back. So I feel that this child is now post-meningitic sequelae. So he agreed to that point. So it is all the discussion that matters more than the diagnosis. So I'm sure you would have taken that message. So it is not something to make you rag or something, but it is how they take it in the exam. So it is a discussion that is going to be mattered in the exam. Be it a DNB much more like that, or any other MD. Sir, am I right, sir?
No, Dr. Madan
From the examiner point of view.
Dr. Madan presented extremely well.
Thank you, sir.
He would get more than 70% marks in a real exam. Madan, well done. Keep it up. But I want
Thank
you
you,
to
sir.
get 90% marks. Okay?
Okay, sir.
Thank you. All the best to you. All the best to you.
Thank you, sir.
Sir,
Over
Somasundram, sir.
to Dr. Somasundram.
Somasundram, sir.
Yeah. So extremely very happy, sir. My only regret was I should have been your PG, sir. Any opportunity for making for any PG, I'll be definitely your PG, sir. 1, 2, 3, still you maintain that, and I enjoyed this past 1.5 hours of that, sir. I'll make sure I come every PG session, every subsequent months also for your session, sir. And it was well taken, and I could see that every time one participant goes away, the other participant comes in. There are many people who have put that they are not able to get an entry ticket into the Zoom room, and it was always many till 9:15 was maintained at 100, 98, then 100, 98, 100. And even our IAP member Shadati has put she was not able to make an entry ticket, so she was into the YouTube live. So thank you very much, sir. So I can see lot PGs from neighboring districts and Pondy also, because we had shared our links to other medical college professors. Prasanna has done that. Prasanna has done lot of efforts to make this happen, sir. And thank our Secretary Subbu sir for creating this link. Be with us, and Nisha ma'am and Prasanna. Thanks a lot, Prasanna. So this has gone beyond boundaries, sir. Many PGs who have benefited out of your extreme knowledge, sir. They will be very thankful to you now today, and hope to continue this for the next 12 months also, sir. Thank you very much, sir.
Thank you.
Thank you very much, and good luck to Madan also.
Thank you, sir.
God bless you, Madan. Yeah.
Thank you, sir.
Thank you, sir. With this, sir, Subbu sir, can we end the session, sir?
Sure, sir. Yes. Thank you, sir. Thank you, everybody. With this, we'll end the session. We'll meet again for the next one session. Thank you so much.
Thank you, sir.
Thank you, SBS, sir.
Not at all.